Hi, my name is Dr. Clemens Muka. Today, I'm going to be talking about a condition that comes about because of immunocompromisation, especially with HIV. Of course, even with leukemia or patients who have a lymphoma, then you often find this condition. You know, I'm talking about an organism that is one of the normal flora in us as human beings. It's in one of the organisms which are normal flora or belong to the normal flora. In fact, this organism is a saprophyte in the lung. You know, a saprophyte is an organism that lives on dead organic tissue or dead organic matter. Better still if you put it that way. So it's just a saprophyte. But when the patient becomes immunocompromised, it becomes an aggressive pathogen because it's taking advantage of the fact that the patient is immunocompromised. In other words, the patient has no immune system to try and fight it or control it. It becomes an aggressive pathogen, you know, a disease-causing organism. This, in the past, it used to be called Pneumocystis carinii. That's the organism. These days, it's called Pneumocystis jirovecii. And it causes this pneumonia, Pneumocystis carinii pneumonia, Pneumocystis jirovecii pneumonia. It's a terrible condition. I've seen it with children. Oh, they, you know, well, the incubation period is about 4 weeks to 8 weeks. And then babies, amen, man, it knocks them. This, before prophylactic therapy was initiated, it used to be the condition that would say that this patient is HIV infected. Once the patient develops Pneumocystis jirovecii pneumonia, as we call it now, then it used to be Pneumocystis carinii pneumonia. Once you see a condition like that, you would say, this is an HIV infected patient. You would go for the test and do everything to make sure that the diagnosis is established. This the infection, it goes into the lungs bilaterally, both lungs bilaterally, and it starts multiplying. And of course, it starts multiplying because it's not counted at all. In the case of an immunocompromised patient, or patient having HIV, a very immunocompromising condition. So it starts multiplying, and it fills a very important area in the lung. It fills the alveolus. Alveolus, must remember, that's a space for gaseous exchange. You need to have our pulmonary artery coming with deoxygenated blood. All the branches of that, even arteries, arterioles, arteries, arterioles, and in capillaries, all of them carrying deoxygen, getting to the alveolus, because there has to be gaseous exchange. In other words, the carbon dioxide must go out into the alveolus, and so that it gets out of the body, it is exhaled, right? And then oxygen has got to come in, and it gets into the pulmonary vein. Pulmonary vein is the one that will transport it to, this is the only vein, we have to remember this. This is the only vein that carries oxygenated blood, because now oxygen from the atmosphere gets into these capillaries, which, the veins, and then these venules, they combine to make a vein, a pulmonary vein. The pulmonary vein will take everything to the left side of the heart. In fact, to the atrium, mitral valve, then straight into the left ventricle, so that it can be pumped out to all the parts of the body as oxygenated blood. That's what happens in the alveolar system. That is what happens in the alveolus. But when there's this problem of multiplication of this Pneumocystis jirovecii, when it multiplies and it comes with its exudates, and all these are packed in the alveolus, and then the alveolus gets hypertrophied. In other words, it gets hypertrophied. It gets larger and larger. Because of what? Because of the multiplication of this Pneumocystis jirovecii. And then multiply, and it's multiplying, giving out an exudate. So this exudate is packed on the alveolus. So the alveolus becomes thickened, hypertrophied, thickened. And now it does something that we haven't seen before. In other words, the part that was supposed to, or the area that was supposed to be occupied with air, it's now getting occupied with the Pneumocystis jirovecii, with the exudate. So this part becomes now consolidated. It becomes consolidated. In other words, it becomes airless. So there's now what is known as extensive consolidation. In other words, the lung becomes airless, becomes extensively airless. And you tell me, how is the patient going to breathe if that is the case? Extensive consolidation. It becomes airless. And if you were to say to this patient, say air, there's what is known as air-to-air egophony. Egophony, it's actually the bleating of a goat. That's egophony. When there's something in the lungs, or in the alveolus of the lungs, and that is not air, the transmission of sound becomes different. The transmission of sound becomes different. That's why we talk of the air to R egophony. In other words, when you say to the patient, say air, what comes out of the mouth is R, because of what is in the alveolus. What is in the alveolus is not air anymore. So the frequency of the transmission of sound is different. And whatever is in the lung chooses which frequency to use. High frequency, low frequency, they tend to go for high frequency. And they'll air, for instance, is high frequency. Air, to say air, that's high frequency. But now to change it, to show that there's something in the lung which is not air, it changes it. It chooses the frequency that will be suitable to the type of organism or to the type of substance that is in the lung. In this case, what do we have? We have Pneumocystis jirovecii, and as it fills up the lung, we call that's a pneumonia now. Pneumocystis jirovecii Pneumonia, and when it is extensive, you have a massive problem, because number one, there's gonna be an insidious growth of respiratory distress, or perhaps maybe better still, there's an insidious growth of, shall I say, the patient is unable to breathe well. And because the patient is unable to breathe well, the patient is now having this shortness of breath. This shortness of breath is insidious. It starts slow, and it grows and grows. It grows and grows until the patient is unable to breathe at all. In other words, the patient is unable, because, and it's understandable, because what is happening, there's a growth of something in the alveolus where there's supposed to be gaseous exchange. There's growth of something that is not air. And that is why you call it a consolidation. It's not air. It becomes a solid substance. It can be pus. It can be water. In which case we are going to say there's lung congestion, water. It can be blood. It can be, if the lung collapses, it will be the walls of the alveolus. The lung has collapsed. So the transmission of sound is going to be very different. It can be, that's why we say there's an air to R of egophony, because of consolidation. And this is an extensible consolidation that has taken everything. It has taken that space which is supposed to be. Remember, pulmonary artery is coming with deoxygenated blood. It's supposed to deposit that oxygenated blood to the alveolus. And the alveolus is supposed to make sure that it becomes exhaled. And what will be inhaled will be fresh oxygen. And it will go through the vein, the pulmonary vein, and until it gets to it gets to the heart. But now, what you see here, you need to check what is known as the alveolar artery. It's alveolar dash A. It's A dash A, which is alveolar artery And this is what you need to check. Is it increasing or is it decreasing? If it's increasing, bad news for the patient. Because it means, what it means, there's a shunt. In other words, there's no ventilation. There's nothing coming in. There's no ventilation. It means there is no gaseous exchange. In other words, the pulmonary artery is not giving up its carbon dioxide. Remember, that's what's supposed to happen, and it is not happening. And how will you see that this is not happening? By an increase of this AA gradient. We say AA gradient. A for alveolar, a small a for artery. And which artery are we talking about? We're talking about the pulmonary artery, the one that brings deoxygenated blood. And we're talking about an alveolar being that space which is supposed to make sure that gaseous exchange takes place. And if this alveolar dash A or A capital letter A dash small letter a, if that gradient grows, in other words, it becomes more and more and more, it means there's a shunt. In other words, there is no ventilation. There's no ventilation. There is no carbon dioxide that is going out. In other words, there's no gaseous exchange. Remember, there has to be gaseous exchange. Alveolus is for gaseous exchange, and that's it. So if this is not happening, then the A, capital A, dash small letter a gradient, that gradient is increasing. And if it's increasing, bad news for the patient. Bad news for the patient. And that's exactly what is happening with Pneumocystis jirovecii Pneumonia. That's exactly what happens. There's extensive consolidation. If there's extensive consolidation, it means that there's extensive lung that an LS lung. An LS lung is not a functional lung, that's for sure. We don't want that. We want air. In fact, we want in the lung, we want air. So now, if you have an LS lung, because it is occupied by something else, it is occupied by this Pneumocystis jirovecii, organism, and it's exudate. So now it means the alveolus is not a functional unit anymore. You remember, it's a functional unit only if there's gaseous exchange. If the carbon dioxide goes out and it is exhaled, and oxygen comes in and it is inhaled. So it gets into the pulp. So we've got to know that. So how do we know that this patient is actually having Pneumocystis jirovecii Pneumonia? How do we know? First of all, if we do histology, and we look at and we are able to isolate the actual organism itself, the actual organism, the Pneumocystis jirovecii, we are able to isolate it, that will be good. But if in addition to that, you have an increasing A gradient, we know that our A, big capital letter, is for alveolar, and we know that dash A, that is pulmonary artery, that artery which is carrying deoxygen. We always looking at that gradient. That gradient is important. It's an indicator to us that there's gaseous exchange or no gas. If the A gradient is small or slow or is low, that's very good. It means there's gaseous exchange taking place. If it increases, we know that bad news. Then this is how if we have isolated Pneumocystis jirovecii. And then we now have a gradient that's actually growing. That is the AA gradient. It's growing or it's increasing. Then we know that we have our Pneumocystis jirovecii pneumonia here. And that's it, know. But we have prophylactic therapy that we use for this. And that's Bactrim or cotrimoxazole, 450 milligrams. We usually give that BD 2 times a day. And we look at the CD4 count of the patient. If the CD4 count of the patient is less than 200, we continue giving it, give it, because the probability of having, AIDS is very high. If you actually at less than 200, it's already AIDS. So, and we know that AIDS patients are targetable by Pneumocystis jirovecii pneumonia. We know that. So we'll give our Bactrim or cotrimoxazole. We'll give it. But there's now a new one that has been trimetrizate. Trimetrizate. This is a new one. And we've not been using it. We've always been using cotrimoxazole. Oh, there's a new one like that. And there's another one that we actually use to treat Pneumocystis jirovecii pneumonia. Pentamidine. Pentamidine, we can give it IV. We can give it. We can inhale it like as an aerosol. And it's better when it's an aerosol. It's better tolerated than IV. IV tends to be toxic. We can do that with pentamidine. It's just that there are problems with it, though we can tolerate it with pentamidine aerosol. Though you can do that, but it doesn't reach the apices of the lung so much. And as a result, then it's not that popular, and people will have to supplement it with oxygen therapy. You'll have to make sure, So for now, we stick to our Bactrim. We stick to our cotrimoxazole. It's doing well that way. As soon as the patient the CD4 count of the patient goes over 200, then we start thinking of once it gets over 200, we actually stop using Bactrim with cotrimoxazole. Right. All one needs to remember with this is that this is a pathogen. This has become an aggressive pathogen, but it was part of the flora, the normal flora of the patient. The reason why it has become an aggressive pathogen is because of immunocompromisation. It's because the patient has fallen victim to HIV. It's because the patient has fallen victim to leukemia. It's because the patient has fallen victim to a lymphoma. That's the reason you are getting, because now this is an immunocompromised patient. And that is why there's multiplication of this in the alveolus to form an extensive consolidation. And we know that we mean extensive airless lung. Thank you.